Hello, anatomy colleagues. This is Dr. Alsop. So we've discussed the bones and the joints and the muscles of the head, and now we're going to move towards the neck as well as the back. And so we'll obviously spend considerable amount of time talking about the vertebral column. We've combined the videos here, so we're talking not only bones as well as joints in this one video. So as you can see, there's a tremendous amount to get through. So let's just dive right in. And we're going to start with the one real bone that's associated with the anterior neck. There are cartilages that you'll talk about associated with the larynx, but in terms of the bones, there's only one. And this is referred to as the hyoid bone or just the hyoid. And it is unique. So you can palpate your own hyoid bone. You can palpate the thyroid cartilage and then move anteriorly, and you're up against the hyoid bone. It's often referred to as a free-floating bone, meaning that it doesn't have a direct articulation with any other bone, but it is very closely suspended and associated with ligaments and muscles in the neck. You can see here again, it's between the mandible, which would be right here, and the larynx, which is right here. So it's kind of this in between. And it'll also play a role in terms of supporting the tongue and kind of moving the hyoid out of the way in order to allow things to move through the gastrointestinal system or in terms of air. And it looks kind of like this wing-shaped bone. All right, now let's spend some time talking about the vertebrae. And you've often heard the vertebrae referred to as the vertebral column. The vertebral column is really a bit more complex. Obviously, it includes the bones, but it also includes all the connective tissue associated with the vertebrae. So all those muscles that are attaching there, any of the ligaments that are in that region, all of that together is vertebral column. And as you would think, its primary role, its most important role is really to protect the spinal cord. So that spinal cord is very well protected within this really bony encasement right here. But one thing you don't think about as much, or I often don't think about as much as I think of the spinal cord, is certain portions of the vertebral column allows movement. So you're going to have flexion or extension or lateral flexion to the side. You can even have some rotation. Some of the vertebrae are going to be more movable than others. Some vertebrae involve no movement. So the sacrum and the coccyx are going to be fully fused and there's no movement there. And then there's differing movements in these more movable vertebrae that are more superior. Also importantly, the vertebral column is going to be a point of attachment for bones and muscles. So you're going to have ribs attaching to the thoracic vertebrae. You're going to have a tremendous amount of muscles in this region. A lot of muscles that we don't talk very much about the details. They play a big role in terms of posture, but those are going to all have some form of attachment to this vertebral column. All right, there are 5 types of vertebrae, and I do want you to know the numbers associated with each one. And we'll start superior and move our way inferior. So the most superior vertebrae, or the vertebrae associated with the neck, are the cervical vertebrae. There are 7 cervical vertebrae in most individuals. Next, moving more inferior, you'll have the 12 thoracic vertebrae. Think thoracic cage or the thorax. Well, that's where the thoracic vertebrae will be. And there are 12 thoracic vertebrae. These are the ones that are going to have an attachment to the ribs. The next are going to be the lumbar vertebrae. These are your largest vertebrae. There are 5 of these. And we'll talk a little bit more about those in terms of herniation. And so these first 3 types are going to be the movable vertebrae. They have not fused together. There will be intervertebral discs in between. Whereas the sacrum and the coccyx, so here's the sacrum, and the coccyx is this fairly small bone right in this region. You can see a little bit better here. These vertebrae have fused together. There's not an intervertebral disc in between. And so there's no movement associated with the sacrum and the coccyx for the most part. And it's the sacrum that's going to have the attachment to the hip bones in this region. So there's generally 5 fused sacral vertebrae and generally 4 fused coccygeal vertebrae. They are going to look more vestigial. They'll have generally a fairly comparatively large first coccygeal vertebrae, and then they get progressively smaller the more inferior you get. I always remember these numbers in particular by thinking about when you eat. You eat breakfast at 7 a.m. You eat lunch at 12 p.m. and then you catch the early bird special and eat at 5 p.m. for dinner. Okay, so let's talk about a few structures that you'll have in almost all vertebrae. And generally the most prominent thing that you see associated with the vertebrae are the vertebral bodies. This is the main weight-bearing component of the bone. This is almost all spongy bone with a layer of compact bone in on the outside externally. And these will be more anteriorly placed. So they're going to be more towards the anterior, where these spinous processes will be more posterior. You can feel those. And projecting kind of away or projecting posteriorly from the body are these little feet, as you can see here, referred to as the pedicles. And again, these project posteriorly from the body, and they unite with the laminae, which are these flat portions. We'll talk about that here. And so the lamina, and it'll differ depending on the type of vertebrae. When we're looking at a lumbar vertebrae, it's fairly small. You can have a larger laminae, say like in thoracic vertebrae. And the laminae are just kind of this flat portion of the bone right here. And generally you'll have a continued projection of the lamina laterally, and these are the transverse processes. So these extend posterior laterally, and these importantly are a point of attachment for muscles for all of the vertebral column, and then for some of the vertebral column, specifically the thoracic, you'll have bone also articulating there. And then last but not least, in this general region, you have the spinous process, and this extends posteriorly. These are palpable. If you feel down the back, the middle of your back, you're feeling all these spinous processes. And in certain regions, specifically the cervical region, these can be bifid, meaning that there can be kind of split into two right here. Now, all vertebrae really are going to have what's referred to as notches. And so we're looking at a lateral view here. Here's that body. So this is anterior. Here's that spinous process. So this is posterior. And you can see that a vertebra is going to have both an inferior notch and a superior notch. And you can really see on this particular one easier. So here's that superior vertebral notch, and here's the inferior vertebral notch for this particular vertebrae. And what will happen is when they are all articulated together, these basically kind of connect to form a foramen. And you can see these really clearly kind of going down the entirety of the vertebral column. And these are referred to as intervertebral foramen or foramina if you're talking more than one. And these are extremely important. This will allow the passage of spinal nerves and their branches from there. So this is how you're getting, so the spinal cord obviously is within this vertebral column, and this is how you're getting the exit of the spinal nerves to go innervate pretty much the entirety of the body. So these intervertebral foramina are extremely important here. All right, now let's spend a little bit of time talking about the individual vertebrae. And so we'll start superior again and move inferior. So these cervical vertebrae are generally the smallest. When we're talking about the movable vertebrae, obviously the coccygeal vertebrae will be smaller. The cervical vertebrae have considerable range of movement, similar to kind of the lumbar. Thoracic will be our least movable, but still with some movement allowed. And for me, when I'm trying to differentiate a cervical vertebrae from the others, I always go to this structure right here. You can see this on either side that's associated with the transverse process called the transverse foramina. Only cervical vertebrae have transverse foramina. So that is by far the easiest way to tell if you're looking at a cervical vertebrae. And this allows for the vertebral artery and vein to traverse this region. And the vertebral artery is very important. It is going to be a branch of the subclavian artery, which is found in the neck. So it allows for the vertebral arteries to ascend the neck, get into the skull, and be one of the dominant supplies of the brain. Okay, so it is one of the main arterial supplies of the brain. So a hugely important artery here. And this is how they travel to get up to the head. Many of the cervical vertebrae specifically C2 through C6 will have that bifid spinous process we talked about before, and you can see that kind of well in this illustration here. There are going to be 3 unique cervical vertebrae. The first is C1, so the very first one, often referred to as the atlas, and it looks very distinct. Generally, you can tell this from anyone else because it looks just like a ring of bone. It doesn't have that vertebral body, which is unique. It doesn't have a spinous process, but it does have these really large superior articular facets right here. And these are going to articulate with those occipital condyles on the occipital bone. So this is going to form that atlanto-occipital joint. And this will allow me to say, yes, I would like to do that. It's all because of this atlanto-occipital joint. Do notice you still see that vertebral foramen on either side. So cervical vertebra, right? C2 is the good neighbor of C1. It's often referred to as the axis. And one of the things you see here that's most dominant is what's referred to as the dens. Sometimes you hear it referred to as the odontoid process. And this projects from the vertebral body up towards C1. And you can see that relationship right here. So this is forming that atlantoaxial joint. And this is a very good example of a pivot joint. This allows for rotational movement and allow me to say, no, I don't want to do that. So that is because of this particular joint right here. The last cervical vertebrae that I want to discuss is C7. So the last or the most inferior of the cervical vertebrae. Often this is referred to as the vertebra prominens, and it is unique in the fact that generally it has the most prominent spinous process. So if you tell somebody to kind of bend their neck, generally you'll see one spinous process that projects the most posteriorly. Generally, this is C7. And this can allow you to count vertebrae to give you an idea of where you're at if you need to inject some type of needle or something into that region. So this is a kind of clinically important region. Other than the more projecting spinous process, the rest of the vertebra is pretty similar to the rest of the cervical. Okay, thoracic vertebrae. Now we're getting progressively larger, so we're not quite as small as what we saw with the cervical vertebrae. There are going to be longer transverse processes. We'll talk about why that is in a moment, but I do want to note that there's less mobility with the thoracic vertebrae than with the cervical and the lumbar, and that makes sense because it has the ribs attaching to it. You don't have as much movement here. And generally, the most unique thing about a thoracic vertebrae is that it has what's referred to as costal facets or demifacets. And so you can see a little bit of one here, you can see a little bit of a one here. And this is where you're going to have the attachment of the rib. So you can see the head of the rib is attaching right here, and then the tubercle of the rib is attaching here on the transverse process. So generally, sometimes it's difficult to differentiate, particularly a more inferior thoracic vertebrae, say from a lumbar. And it's the way you can do that is if you see a facet or demifacet, you know you're looking at a thoracic vertebrae. Last but not least are going to be the lumbar vertebrae. Again, there are 5. These are giant. They are going to lack both transverse foramina and costal facets. So this is kind of the way, particularly this, you tell, say, T12 from L1 because they're generally pretty close in size. They do have prominent superior articular processes, but generally just overall, the way you tell a lumbar vertebra is that it's big, it's super big. It's bearing a lot of weight, so it needs to be on the bigger side. Sacrum and coccyx are super important, but we will discuss these in the context of the pelvic girdle. So we'll come back to this, I promise. All right. I do want to note some functionally important things regarding the vertebral column. And the first is curvatures. If you look at a typical vertebral column, it is not a straight line. And that's good. You need a little bit of flexibility. You need a bit more shock absorption. And these curvatures are naturally occurring. You want them. You may not want them to be too curved, and we'll talk about that in a moment, but you do have these naturally occurring curvatures. And they're going to go in specific ways. You're going to have the thoracic and sacral kyphoses. This means that they are going to be concave more anteriorly. And then you have the cervical and lumbar lordoses, which are going to be concave more posteriorly. And these can actually be separated into primary and secondary curvatures. So primary curvatures, meaning that these develop during the fetal period in relationship to the fetal position. So there's just generally in the fetal skeleton vertebral column, there's just going to be the one curvature. And then these maintain in the thoracic and the sacral region. So you can see that thoracic curve and the sacral curve are going to be in this direction. So these are primary curvatures. Secondary curvatures develop later in life, and these result from extension from fetal position. So these are going to occur in the cervical and the lumbar region. So let's think about things that happen that could allow for these curvatures to develop. So think about in the cervical region, what's something that happens in that region very early on in terms of the juvenile period. Think about, you have to always support the baby's head, right? Well, eventually they can hold that big head up on their own, and that's going to cause this development of this secondary cervical curvature. What about in the lumbar region? What's something that happens a little bit later, but still fairly early on? In terms of walking, that lumbar curvature will develop around that time, and as those muscles in that region get stronger. Now, of course, you can have abnormal curvatures. So those that we just talked about are very typical. You want them to happen, but obviously these can be accentuated to a point where they become pathological. You can have an excessive thoracic kyphosis. Sometimes people just say kyphosis as a pathology. Generally, it's really the excessive kyphosis. So this sometimes is referred to as a dowager's hump or hunchback. Generally, we try not to use those terms anymore. Want to use the scientific terms. This is often caused by effects of osteoporosis. So if you have like many microfractures associated with the vertebral bodies, that can allow for this excessive kyphosis to occur in the thoracic region. You can also have excessive lumbar lordosis. A little more commonly, sometimes this is referred to as a hollow back. Think of how hollow that can be there. This is often characterized by an anterior tilting of the pelvis. So that pelvis is kind of projecting a bit too anteriorly. And this is often associated with weakened trunk musculature, but often sudden weight gain. So if there's, and pregnancy is one of those regions as well, obviously you have a considerable amount of anterior weight in this region, and that can certainly affect the associated curvature in that region. Scoliosis is not an overaccentuation of naturally occurring curvatures. This is actually going to be an abnormal lateral curvature. So you can see in this particular illustration that the vertebral column is projecting a little too laterally in this region. You can see a little laterally on here. There are many causes for scoliosis. There can be structural causes, as in there could be issues with the muscles or the ligaments in the vertebral column that cause this to kind of occur. Or it can be idiopathic, meaning that we don't know the actual reasoning behind why the individual has scoliosis. This is one of the more common of the abnormal curvatures. All right, last but not least, let's talk about joints. And there are many joints associated with the vertebral column, but we're really going to focus in on one type, which are the intervertebral discs. And we mentioned these a little bit when we were talking about joint basics. So if we're looking here, here's a body, and in the middle, you're going to have this joint here, which is the intervertebral disc. And recall from our discussion, this is a type of symphysis. It's in the midline, so it makes sense for it to be a symphysis. Again, that's a cartilaginous joint. You're going to have an intervertebral disc located between every single set of bodies, except for between C1 and C2, which makes sense because that's going to be that rotational joint there. And any of the non-movable vertebrae, so none of those sacral or coccygeal, those are going to be synostoses because those are bony joints at that point. But there is one between L5 and S1. This is the most inferior one. The intervertebral discs can vary considerably in terms of thickness. And obviously, as you would imagine, they will increase in thickness the more inferior you go. So the lumbar vertebrae have fairly thick intervertebral discs. There are two major components of an intervertebral disc. As any outer layer would be, the annulus fibrosus is going to be the more protective layer. This is composed of fibrocartilage. And so if you're looking at just say a lateral view, if you're not looking at internal view, you would only be seeing the annulus fibrosus. It is going to be thinner posteriorly, and that will be important in just a moment. So keep that in mind. On the inside, you're going to have a nucleus pulposus, which is the inner component. It is semi-fluid, dependent on an individual's age and health. The fluidity within will vary. And you can have what's referred to as a herniation of the nucleus pulposus. Sometimes this is referred to as a slip disc. Generally, we try to keep herniation there. Herniation just means something is moving out of the place that it should through another structure. So what we have here is that you have a herniation of that nucleus pulposus through the annulus fibrosus. And again, it's herniating in that more posterior portion that we talked about is a little bit thinner. So typically that herniation occurs posterolaterally, and often it can happen in any vertebral level, but generally it happens between the L4 and L5 vertebrae or between the L5 and S1. Those are the most common regions for those herniations. And as you can really see here, that has some pretty big implications. If it went straight posteriorly, that could herniate and impinge right on the spinal cord. But generally in this posterolateral portion, you can see that it's herniating back towards, it could affect a little bit of the spinal cord, but generally it's right around that intervertebral foramen region. So right there associated with that spinal nerve. So you have that pinching of that spinal nerve, and that can have sensory implications as well as motor implications. So affecting the muscles that specific spinal nerve innervates. All right, excellent. So we went through quite a bit. The vertebral column is one of my favorites, but it is one of the more complex regions of the body. Again, this is an important thing. This will come up in terms of any type of health science because this is an important region, something associated with pain. So herniation, again, can happen in any intervertebral disc. However, it is most common with intervertebral joints at which vertebral levels? Is it the cervical? Is it the lumbar? Is it the thoracic? So pause the video if needed. And when ready, let's talk about how B is the correct answer. It is generally that lumbar region that you would have a herniation. You can have it at a cervical vertebrae as well. That's a little bit more common than, say, a thoracic, but the lumbar has the highest frequency. And that makes sense. Generally, if you think about lumbar pain, that could have to do with the muscles in that region. That could have to do with the ligaments, but it also could have to do with a herniation occurring of the intervertebral disc. Back pain is a really complex region and hard to really hone in on what exactly is causing the pain. But this is one possibility. All right, thank you so much for your time here. This was a little bit of a longer video. In the next video, we'll talk about some of those deep back muscles, as well as a few of the muscles associated with the neck. Thanks for your time here, and I will see you in the next video.